Hello and welcome everyone to Ask Your Doctor. This is an informative health session sponsored by My American Doctor. They are a group of highly trained and experienced doctors that represent all specialties and provide second opinions throughout the country. We are not here to give individual medical advice or treatment plans, but to just give a general idea of certain conditions. If you still have questions or need further clarification, please feel free to get in touch with us. I do encourage the live audience here to ask questions. We can answer those live here as well. Or you can visit our website at myamericandoctor.com or go ahead and give us a call at 919-914-941-494 to book a second opinion consultation with one of our specialists. Today, we are honored to be joined by one of the top neurologists in the United States, Dr. Kavilaveettil. She is board certified in neurology, clinical neurophysiology, electrodiagnostic medicine, and headache medicine. She brings expertise in treating epilepsy, neuromuscular disorders, movement disorders like Parkinson's disease, and complex headache syndrome. Today, we'll discuss some of the most common neurological concerns faced by patients, particularly those in the Indian community. From epilepsy to Parkinson's and myasthenia gravis to headaches and migraines, we aim to understand the latest in diagnoses, treatment, and lifestyle management. Hello, doctor. Thank you for being here today.
Good morning, and thank you for the opportunity.
Of course, yes. So, where are you joining us from, just so we know where you're talking from?
I am from Florida, Tampa, Florida, warm
Awesome.
place.
Yes, right. Awesome. Well, let's get started here in epilepsy first. Could you just kind of explain in very simple terms to our audience what exactly is epilepsy?
Epilepsy is a brain disorder with the recurrent and unprovoked seizures. If you had two unprovoked seizure, your chance of having another seizure is high, so it is called epilepsy, recurrent seizure. Or you had only one seizure, but you had a predilection to have more seizure based on your genetics or structural abnormality or metabolic abnormality, then again, that is an epileptic seizure. Then what is seizure? Seizure is a sudden and excessive abnormal activity from the brain. And depending upon the location where it's generated, you would have different symptoms from alteration of sensation to convulsions with involvement of breathing. And this has a profound effect, and epilepsy is a very common disorder across the globe.
Okay. Yeah, thank you for sharing that. So what are some of the most like common causes or triggers of epilepsy in adults then?
So the causes of epilepsy, we could say in most common six conditions. It could be a structural abnormality, means somebody had a stroke, they have a scarring in the brain, or you born with a condition with an abnormal brain cells to genetic conditions, metabolic conditions, autoimmune conditions, infections and inflammatory conditions, then they're a class unknown to us to this age. But we're looking into the future to look more genetic and channelopathies causing the seizures. So these are the causes of the seizure. When somebody is diagnosed with epilepsy, the triggers are if they miss their medication, that's the number one cause to cause a breakthrough seizure, or lack of sleep, or they are dehydrated, metabolic abnormalities, vitamin deficiency, alcohol, certain prescription medications like tramadol, or over-the-counter medications like diphenhydramine or pseudoephedrine. Those can decrease the seizure threshold. So once you are diagnosed with epilepsy, you have to have a scheduled lifestyle. It's good sleep habit, diet, and drink enough fluid. Make sure that you don't overexert, especially when you travel, jet lag, and time difference. So all can precipitate a breakthrough seizure.
Yeah. Yeah. So how do you typically then diagnose epilepsy or treat it in your practice?
Just like any other neurological condition, history is very important.
Mhm.
And as we were talking about, the structural reasons can cause seizure. Even if somebody had only one seizure, we had to get the MRI with the special cut, which we call a coronal flare, to look for any kind of scarring in the brain. There are people, they had febrile seizures, has increased risk of having seizures in the future. So we look for the temporal lobe, which is a common seizure focus, to see any structural abnormality there, and also other developmental anomalies. So we definitely need an MRI of the brain with and without contrast. And then
Mhm.
we do electroencephalogram or EEG. The routine EEG is done 20 to 30 minutes recording. And if you don't see anything in that EEG, that doesn't mean there is no increased risk of seizure. Because
Mhm.
EEG is a measure of the brainwave activity at the time we do it. If we are lucky, we may find something called interictal discharges. Even if you don't see seizure, you may be able to see the spike where it is coming from. That tells us where the seizure focus is. In
Mhm.
certain people, we don't even see that at all because at the time we record it, there's nothing going on. So we have to do an extended EEG. We do have the opportunity to do an ambulatory video EEG. The same, the scalp electrodes we put on them, they go home typically for 72 hours because if somebody had a recent seizure, if we do a 72-hour EEG, there's almost 96% we are able to pick up the abnormality. Especially it's read by an epileptologist, which is a specialist, treat the epilepsy. And we had the ambulatory EEG or long-term EEG in the hospital. It's similar, but it is concurrently monitored. That could be also normal. Then you go with the history. Patient has a stereotypical episodes. Based on your expertise, you have to decide to treat them. In
Mhm.
certain cases, we even have to do more invasive, like a stereo EEG, to detect, okay, is this episodes are actual seizures or not? Because we want to exclude other conditions like syncope, passing out. Those are all could mimic a seizure. We do not want to treat those conditions as seizures. So to diagnose and to exclude other conditions, we do these MRI EEGs.
Mhm. Yeah. So just curious question. These are then common practices that you do or doctors do when someone comes in and they've had a seizure. You do these MRIs, you do these scans. These are just kind of common things that you guys do no matter what.
What the condition is, yes. Any episode that could sound like seizure, they passed out, they had few jerks. It could be what we call a syncopal seizure because of lack of blood flow to the brain. There were a few seconds of seizure. Those are not epileptic seizures. So
Mhm.
we do not want to treat somebody who do not have epileptic seizure, or if they had an electrolyte abnormality, they had a one-time seizure. That's what the definition is unprovoked seizure. The
Mhm.
provoked seizure, somebody had alcohol, drugs, or metabolic abnormality,
Mhm.
they do not have the tendency to have a future seizure. So we cannot give them the medication to prevent those kind of seizure. So to exclude that, we had to do the EEG. And for a person we do think has epileptic seizure, we have to locate where the seizure coming from. Because it's
Mhm.
important if it's coming from the whole brain is seizing or one particular part of the brain, like a focal onset seizure, which help us to pick the right anti-seizure drugs. And also if the patient turned out to be a refractory seizure or difficult to treat seizure, if they opt to do surgery or there is an option for surgery, we need to see where exactly the seizure coming from.
Okay, yeah. So that was kind of my next question here then. Are there surgery options then for people who have epilepsy, or what are some maybe more advanced treatment options that you have?
We do have a lot of new anti-seizure drugs which are beyond the scope of our discussion today. Luckily, we do have a different mechanism of action, very powerful once daily medications. I'm going to skip all the names, but if somebody is on two appropriate anti-seizure drugs, with the appropriate dosage. If they continue to have a breakthrough seizure, we call it a drug-resistant epilepsy. Unfortunately, certain type of seizure disorder, especially a focal onset with a generalized seizure, 30 to 40% of people have drug-resistant epilepsy. If they are already on two medication, adding a third medication, maybe 5 to 10% may get some reasonable seizure control. And
Mhm.
if they don't have an appropriate seizure control with that, then we do have some neuromodulation therapies, technological therapies like vagal nerve stimulator, which is, or VNS, which is like a small pacemaker-like device is inserted on the chest area with the lead wire that is wrapped around the vagal nerve, and it gives a continuous and intermittent stimulation. And the newer devices has the ability to detect based on the heart rate the patient is going to have a seizure. So it could give another auto stimulation to prevent that develop into a full-blown seizure. And patient also has a magnet or family can use if they see the patient having a seizure, they just swipe the magnet over to prevent it. It does have an additional 30 to 40% effect on refractory seizure. Then we do have a responsive nerve stimulation, which is a device that goes on top of the skull. That has to be done by a neurosurgeon. And the lead wire goes into the seizure focus. And the advantage of RNS is it concurrently records the EEG. And we have deep brain stimulation, which is again like a device goes into the chest area with the lead wire going into the thalamic area. So these are device or neuromodulation therapies. And
Mhm.
epilepsy surgeries are, we do have um, different options depending upon the patient's seizure focus. It could be if they have a lesion like a vascular anomaly or there is a structural abnormality, they do a lesionectomy. That particular part of the brain is removed. After extensive workup, make sure the patient's memory and language are preserved. So they have
Mhm.
to undergo a battery of testing before we subject them to epilepsy surgery. And maybe brain mapping, stereo EEG to precisely locate where the seizure coming from. So lobectomy, they could actually remove the lobe, they could remove the lesion, and for generalized refractory seizures, callosotomy means like putting some holes in the connection part of the brain, or LIT. It is a laser interstitial thermal ablation, then radio ablation to the focus. So various surgical options are available. And with the appropriate surgery, there is almost 80% seizure control for certain type of seizures, which is amazing for patients with seizure, like 80% seizure control. And with the new AI technique, this neurosurgeons or stereo neurosurgeons are able to precisely put the leads even for that neuromodulation. So the surgical success is much better with the aid of the modern AI technologies.
Yeah,
It's a
that's
very exciting field in epilepsy. And then in the future, the medications are going to be very personalized medication. If we are able to find the genetic cause of the seizures, so we could personalize the therapies. That is the future of epilepsy treatment.
That's amazing. That's awesome. There are so many treatments available or surgeries or just different things that can guide people through these. Because, even when we're talking about seizures, people who may have not even experienced them before, we understand how crazy they could be, for somebody's life, how debilitating they could be. So when we're talking about this, could you maybe talk about the impact that epilepsy or seizures could have on someone's daily life, maybe in terms of work or driving or even just social activities? Could you kind of talk a little bit about this topic here?
So the impact is significant, emotional to social to economical.
Yeah,
Impact of social and emotional is when you watch somebody is having a seizure,
yeah,
it is a scary experience for a family member. And typically seizure lasts for the 30 seconds to 90 seconds. But every
mhm,
time you ask a family member, they would say it lasted 5 minutes. If a seizure is ongoing for 5 minutes, it's detrimental to the brain, can cause permanent damage. But in their mind, it seemed like it lasted forever. It's a traumatic experience.
yeah,
And social impact also. There is certain countries, or even in United States, people don't want to reveal that they have seizures. They're afraid they are not going to be hired for certain jobs,
mhm,
and there's social stigma in certain countries. Just because they are taking medication, they could be tired, and that could be considered as something effect from the seizure. Um, Two, there is increased risk of death in patients with epilepsy, especially generalized seizure and complex partial seizure. In particular, more nocturnal seizures. The seizure comes at nighttime. It is called SUDEP, sudden unexplained death in epilepsy. That is a pretty common 1 in 1,000 patients.
wow,
There is that is a serious condition. So we definitely need to make more awareness for epilepsy and people to seek out the treatment from medication to surgery. And now we do have a lot of new rescue medications intranasally available to keep at home if family is seeing or watching somebody having a seizure. They could use that intranasal forms. Also, when they are traveling, they should be taking that with them. Like somebody is traveling on the plane, they have a seizure. These medications are just the same thing as the EMS used to break the seizure. And driving restrictions can impact one's life, especially in Western world. Our life is incapacitated if you cannot drive to job, to go, depending on somebody. Each state has its restriction from 3 months to 6 months, seizure free
mhm,
period before you go back to driving. And certain state it has to be approved by the Department of Motor Vehicle. They had to go through again a repeat EEG documentation. So that's has a significant financial and social impact.
yeah, yeah. Awesome. Well, thank you for sharing that with us, Doctor. Treatment plans and different things that are available for seizures and people who are suffering from epilepsy. Kind of want to move into our next topic here, myasthenia gravis. It's not commonly discussed in India or even kind of in the Western world here. I have never heard of it before. So could you kind of explain what this disorder is and how it presents itself?
Myasthenia gravis is a very underdiagnosed condition.
Mhm.
It is a disease, it's an autoimmune disorder that affect the nerve muscle junction. When a signal comes from the brain that comes through the nerves, and the nerve endings are connected with our muscles. So that junction, there is not a direct connection, it's a chemical connection. And the chemical connections are um, impacting the muscle movement. And the autoimmune disorder, myasthenia, develop people with myasthenia has antibodies in the neuromuscular junction that prevent that transmission. And the symptoms are presented with the fatigable weakness involving the skeletal muscles, in particular, our voluntary muscles. The group of muscles those are affected are the eye muscles. People present with the droopy eyes, it varies from morning to evening, or they are reading. They are the sustained contraction of that muscle. They feel like they have double vision. Then it can affect your speech. Somebody's over the phone for an hour, their speech gets slurred and um, cannot understand. It can affect your swallowing. You're chewing something, your chewing muscles. You feel like your jaw get tired.
Mhm.
Your breathing muscles can be affected. You're walking, you're winded, you're short of breath, and you're chopping, doing something, or combing and or straightening your hair. You feel like your arms are getting weak, or you're climbing stairs. You cannot. So it's a fatigable weakness. That is the characteristic of myasthenia. It is actually an underdiagnosed disorder because when you feel like you're tired, if never seek medical attention or the physician never look into that, you never go into to understand what's going on with the patient. We also have to exclude other conditions that can cause weakness.
Mhm.
And myasthenia is in particular affecting females younger than 50 years old or
Mhm.
male over 60 years old.
Okay. Yeah. So how do you diagnose this then? Are there blood tests or other just things like how do you know? How do you know?
People usually to in our practice, anybody with the double vision, they're sent
Mhm.
to me to look into is it myasthenia. There are a lot of other causes of double vision, but that's how they usually present. Start with the eye muscles. They have droopy eyes. They could have double vision, and in um, within the next 2 years, if they have a tendency to have a generalized myasthenia, as we are talking about affecting the speech and the swallowing, the respiratory, and the extremity, they will develop into that generalized myasthenia in the first 2 years, almost 80% of the patients.
Mhm.
So the diagnosis when somebody comes with either fatigable weakness or eye muscle weakness, we do a blood test, the antibodies, acetylcholine receptor antibodies, MuSK antibodies, LRP4 antibodies. Then there's another group of neuromuscular junction disorder which affect the antibodies on the nerve end rather than the muscle end. So that is called the Lambert-Eaton myasthenic syndrome. So we check the antibodies for that. We also do blood tests to exclude other conditions like thyroid, other muscle diseases causing the weakness, and also do a CT of the chest because there's a gland called thymus gland that regulate the immune system, especially T cell mediated immune system. In patients with myasthenia, you may see this gland may be enlarged, called a thymic hyperplasia, and a few percentage of people may have thymoma. So removing the thymus gland actually prevent a rapid progression of the myasthenia gravis.
Mhm.
So whether a patient has a thymic hyperplasia or thymoma, I do recommend if they do have myasthenia, we remove the thymic gland.
Mhm.
So we do get all this work of CT. And if everything is negative, this routine blood test and everything negative, your clinical suspicion is high for myasthenia, you would do a nerve study, EMG, electrodiagnostic study.
Mhm.
You try to mimic what in real life, because the fatigable weakness or the repetitive motion causing the weakness. So we actually do a repetitive nerve stimulation, stimulate that particular nerve to make the muscle move repeatedly to see if there is a classic pattern. We see almost a more than 10% decrement in that particular testing. So
Mhm.
that is called RNS. That is not exclusively diagnostic of myasthenia, but in the correct clinical context, you could say that it's positive when you treat them for myasthenia. There is a group of patients, we did the RNS, it's inconclusive, or patient not able to tolerate the testing. We could do a single fiber EMG. You isolate one muscle fiber to see, is it working in synchronous with the rest of the muscles?
Mhm.
Because of the blockage at the nerve muscle junction, the fibers can work in their own way. So there is a lot of variability. So we measure that, which is actually very typical for myasthenia or neuromuscular disorder, if that is abnormal. I do all that in my office,
Okay.
and um, it needs to be done by especially trained neuromuscular trained or clinical neurophysiology trained neurologists.
Mhm. Yeah. So have you found that this is like genetic, or how are we getting this? Like how does this happen?
It's an autoimmune disorder. There is a genetic predilection, and there is
Okay.
also congenital myasthenic syndrome. But just like any other autoimmune disorder, or if the family members have other autoimmune disorder like lupus or thyroid disease, autoimmune hepatitis, rheumatoid arthritis, they come with the weakness. There is a little association with those. We do not have any particular gene to designate this is causing. It's more like can run in the families, just like any other autoimmune disorder. The
Okay.
congenital myasthenic syndromes are presented usually in childhood, and there's one particular variant that comes later in life. It's a late onset congenital myasthenia that is more common in men.
Okay. Interesting. Interesting. So that first kind of common telltale sign is that blurred kind of double vision. Is that typically what you see patients come in is with that first?
Yes, most of the time. Or they say that they do have weakness, unexplained weakness. I can walk, I can climb. And most of the time, myasthenia is not diagnosed too quickly. People go around and have other diagnoses. They don't get better. It's an underdiagnosed condition again. And it is not uncommon in India. It probably underdiagnosed.
Yeah. Yeah. Well, thank you for shedding light on that because, like I said, I've never heard of this before. So I appreciate you kind of shedding more light to this underdiagnosed condition here. Moving on to our next topic, Parkinson's disease here. It is increasingly seen in aging Indian populations. How do you typically diagnose Parkinson's disease?
Parkinson's disease is clinical diagnosis, history, and observation. And it is actually very common, 1% over 60 years of age. And as the age increases, increase incidence of Parkinson's disease. And the
Mhm.
global prevalence is almost 8.5 million people worldwide based on a study in 2019. So it's a significant effect. And almost 2.45 times more men are affected than women. The clinical diagnosis is important. Sometimes they come with difficulty walking or slowness, tremor. Most of the time, the tremor is the presenting symptom because it's more visible.
Yeah.
And family notice they are walking slow, and people, they are very in tune to their own body. They may come to you earlier because they feel like their body is stiff. And I have several patients came to me for refractory back pain, but there's nothing in the MRI to explain, and it's that body rigidity that is causing them having the pain. So the classic symptoms of Parkinson's disease are tremor, which is mostly typical for a resting tremor. We call it a pill rolling tremor. The hand goes like this. And it affects both sides. One side can be affected more. And rigidity, as like the whole body is rigid. And bradykinesia means the movement is slow everywhere. There
Mhm.
are people, when you talk to them, you feel like they are just staring at you because they have decreased eye blink and they move slowly. When they walk, it's like a very slow walking. They stooped posture because the body is like trying to adjust for the center of gravity. And some people have significant balance issue, posture instability. These are
Mhm.
the classic symptom. Then there are a lot non-motor symptoms of Parkinson's disease which are not very well recognized with the family or even in medical community. They do have extreme fatigue, unexplained fatigue. They could have chronic constipation, just like the slowness of the body, the bowel slow to the point that could cause a fecal impaction can
Mhm.
cause a hospitalization. So it is very important to have good fiber diet for patients with Parkinson's. They could have autonomic problem, means they do feel like they cannot tolerate heat. The next moment they cannot tolerate cold. So that heat cold intolerance. They could have sleep disturbances to the point they act out during dreams, like a REM sleep disorder. And certain type of Parkinsonian syndromes have hallucinations, and their voice can be very slow, and they do have trouble with the swallowing. And sometimes, because of that, the pharyngeal muscles, the throat muscles are not working in, in coordination. You could have accumulation of the saliva in your mouth. You could have drooling, excessive drooling. Some people have a lot of kerchief or tissues. It's very disturbing and also have increased risk of having infection. Certain patients with Parkinson have abnormal posture, so their head or neck to be twisted to one side. And if they also have drooling, there is a hygienic issue and increased risk of infection. Then also can have a urinary frequency and unexplained nerve pain. So
Mhm.
those symptoms can make their life miserable, even though we treat and the recognized symptoms. So it's a whole lot of other symptoms, including some memory problems in later stages of Parkinson's disease.
Yeah. So do you typically see these kind of symptoms progress then? Are there different stages to Parkinson's disease?
Um, Disease progression is individualized.
Mhm.
Um, if they start or they have an early onset Parkinson's, they
Mhm.
do have a tendency to have a fast progression, especially young men. If they do have early diagnosis of Parkinson, the progression is fast. Otherwise, it's depending upon their lifestyle, and we cannot predict who is going to have more a protracted course of the disease. The stages are, they're typically 5 stages based on their activities of daily living. In stage 1 and 2, depending upon is it one side more affected than the other side, and their mobility, and do they use any assistive device to walk, and do they need any assistance? When it comes to that they need an assistive device and need assistance to walk, that is stage 5.
Mhm.
Otherwise, based on the stage, do we decide the treatment? Not really. So this is
Mhm.
just to assess the functional abilities, not much to do with the treatment decision. The
Mhm.
treatment decision comes actually depending upon the symptom. If a patient comes with a minor tremor, it doesn't bother them. They're a right-handed person. The tremor
Yeah.
is on the left side and they have other associated symptom, and we diagnose them with Parkinson's. I give them the option whether they need to be started on the medication, because we do not have no cure for Parkinson's disease.
Mhm.
We are providing the dopamine from outside, which is Parkinson's disease is degeneration of the dopamine producing cells in the midbrain, um, substantia nigra. So we provide the dopamine to smoothen out their symptoms. So there is no need to treat them if they do not have the symptoms affecting their quality of life or activities of daily living. When we start the treatment, you start a smaller dose to avoid any kind of future complications. We do have a lot of newer treatment options for Parkinson's disease. And
Yeah.
also, when there is a concern about all the tremors are not Parkinson's disease, it could be
Mhm.
essential tremor. It could be a Parkinsonism related to some antipsychotic medications. So when in doubt, you could do a scan called DAT scan. It's a
Mhm.
nuclear scan. It actually assesses the dopamine pathway. It doesn't differentiate between Parkinson's disease and other Parkinsonian disorders, but it differentiates between essential tremor and Parkinson's disease or drug-induced Parkinson's disease.
Mhm. Yeah. So when we talk about those kind of stages, then do you typically start treatment then for patients when they are kind of later in the stages of Parkinson's?
Not necessarily if it's a right-handed person, they do have
Mhm.
the tremor, it affect them, or if they do have significant rigidity, it affect their locomotion and walking, definitely will start the treatment. The
Mhm.
treatment is physical therapy and stretching exercise are very important. I tell all my patients 50% of the treatment is exercise, physical
Mhm.
therapy, occupational therapy, stretching exercise, speech therapy. The other 50% is dopaminergic medication. No matter how many medications we add, that
Mhm.
50% of the therapy with the daily stretching, that could be rock steady boxing, which actually give a lot of exercise to the upper extremity and trunk, and posture to swimming, whichever is appropriate for the patient. Or it could be stationary biking for the lower extremities. They have to do minimum 4 days, 30 to 45 minutes exercise. Then the medications come. We start a smaller dose depending upon the symptom. And in the United States, we have to look at the insurance availability of the medication, start an appropriate dopaminergic medication.
Okay. Yeah. So movement is very, very important in this kind of treatment of this disease here. Is this genetic, or are there kind of certain things like drugs or alcohol or anything that could cause this?
Parkinson's disease is a neurodegenerative disease. So that's why as we get older, we have more tendency to have it. There is 10 to 15% is familial Parkinson's disease. There are specific genes identified. So those are going to be studied, and maybe we'll have more personalized treatment for that genetic type of Parkinson's disease. But
Mhm.
majority of Parkinson's disease are neurodegenerative. You could have Parkinsonian symptoms after you had a stroke affecting the dopamine pathway and certain type of toxins that affect the um, dopamine pathway, certain like toxins, drugs that can cause. So there are various conditions, but those are not treated with the dopaminergic medications.
Okay.
This is, we're treating the Parkinson's disease or the Parkinsonian symptoms of Parkinson's plus syndrome with the dopamine medications. So the drug-induced Parkinson's, or sometimes people develop Parkinsonian feature after they have a cardiac arrest and they have a decreased oxygenation to that area. So they will present with the tremor rigidity that is not actually Parkinson's disease.
Okay. Yeah. So there's been some talk, and I've heard people using Botox in the treatment of Parkinson's. Could you kind of talk a little bit about that?
The Botox is more for two distinct symptoms in Parkinson's disease. One is for the dystonia. As we were talking about, somebody had a persistent contracture of a group of muscle and keeping that particular muscle in a way. The most common involve the neck area called cervical dystonia. Sometimes people have it in their hand, their food. It could be persistent and can cause pain.
Mhm.
And also advanced Parkinson's patients, if their head is to one side, it's so difficult for family to change their clothes, and it is difficult. In that situation, we use the Botox to the particular group of muscles which are in persistently in contractive state. That is one indication for dystonia, cervical dystonia or localized limb dystonia, to lose the muscle. But we have to keep on doing that. It's not a treatment, it is a symptomatic or symptom relief treatment. Then
Mhm.
the other condition we use Botox for Parkinson is excessive drooling or sialorrhea to the glands, the salivary glands. You do small dose of injection, it decreases the excessive drooling because it's important for certain patients. They can choke on their own saliva. They could have aspiration pneumonia from that. So it's very important, and it's a life-saving for certain patients with especially dysphagia or swallowing difficulty and sialorrhea.
Okay, yeah. So kind of in summary here, what are some symptoms then and things that either friends or family of these patients, what could they look for in terms of they haven't been diagnosed yet with Parkinson's? We're not really sure what's going on. What are some of the kind of smaller symptoms then that these friends or family could see in this individual?
When you see they are like slowing down, stooped
Mhm.
posture, tremor, and you feel like they have no expression on their face. So that's a
Mhm.
sign of decreased movement. And they have to see a neurologist. And if the diagnosis is made based on clinical um, clinical examination and history, start the exercise and good nutrition, and also fiber diet. A daily exercise, fiber diet, and support is very important.
Mhm.
And they should be aware of these other non-motor symptoms we discussed, generalized tiredness, sleep, sometimes acting out during sleep could be dangerous to patients, and other symptoms, if they say nerve pain, they experience that, the hallucinations. It's always good for family to educate themselves so they could be a part of the treatment decision, the medication. If the medications causing a lot of side effect, like the medication itself can cause abnormal movement, cause dyskinesia, or if the patient has one side is more affected, the tremor, and it's a patient is young and functional, we do have a lot of neuromodulation therapies to treat for Parkinson's disease. We moved from the surgery. In the past, they did surgery for particular part of the brain called thalamus and globus pallidus. We moved away from that. And now we do have this neuromodulation with the deep brain stimulation, which can help for the movement, the rigidity, and the tremor. Or if they have a tremor, predominant Parkinson's disease, and it affects only on one side, they have the option of doing a focused ultrasound, which is a very less invasive procedure. So deep brain
Mhm.
stimulation has improved um, quality of life for many people, and they do have the ability to have different settings, like they do talk and they want the speech to be better, so they could pick a setting that their tremor is there while they are speaking, their speech is more controlled. Then at times they feel like they're doing something, they're cutting, they're eating, they want the tremor part to be better, so we could actually adjust the settings to depending upon the patient's symptom, and we could give them different options in their
Wow.
cell phone. So they could pick each one depending upon what they do. And certain type of DBS, we could remotely adjust the setting. So we're moving more
That's
into
amazing.
global treatment. It's
Yeah.
exciting.
Yeah, yeah, that's amazing. Yeah. Before we kind of close out here, I know we could speak about these topics for so long. We appreciate all of your insights so far. Before we close out here, could you share one message to all of our viewers and listeners here who might be kind of hesitant to seek neurological care or maybe are a little bit confused about their symptoms and things they're going through? What is one thing that you could share to our viewers today?
I wish we had more time to talk about this exciting topic. We
Yes,
just
yes.
had a little itty bitty um, discussion about the three major interesting neurological disorders. But if you or your family or friends, they are in concern about any of this neurological disorder, please don't hesitate to consult us, my American doctor, for a second opinion. And thank you for everybody joined today. Hope you learned something about these important neurological disorders, and we do have expert in every field. So thank you again, and thank you, Ariana, for modulating the talk.
Yes, of course. Thank you so much for being here, sharing everything that you did today. It's very insightful, and I'm sure that the audience and I included really appreciate all of your time here. Thank you so much for being here. Have a wonderful rest of your day.
Thank you.
Thank you. Bye, everyone.